major issues in cardiology. I hope you shall have some information. If you have any questions, you can stop me anytime. So the first session will be about introduction to ECG. And I know we have different levels, medical students, sanitarian, sanitarian, ABAR, AMSA, science. So if you have any questions, you can stop me. So the first talk is about introduction to ECG. Definitely, so what is the ECG? Simply ECG, it's a recording on a paper of the electrical activity of the heart. So whatever goes in the heart is transmitted through wires into that machine, and that machine translates this electrical activity into a paper that is moving. And it shows the electrical activity of the heart. So we know the heart electrical activity starts from where? The sinus node. The sinus node is on the top of the right atrium. And then the impulse travels from between both atrium and goes down to the AV node. But there is a delay. So that delay allows the blood to travel from the atrium into the ventricle before the activation starts in the ventricle. And then it goes through the S bundle, and then to the right and left bundle branches, and then into the Purkinje fibers, and then you start to have contraction of both ventricles. Right. So what's the heart rate or the heart rate of the pacemaker of the heart, the sinus node? So from 100 to 60 when you are resting. So the sinus node heart rate is 100 to 60, and the AV node heart rate is 40 to 60. So if the sinus node does not work, the AV node will take over. So it's 40 to 60, right? And the bundle of His rate is 20 to 40. So as you go down, the heart rate will slow down. So now, why do we do ECG? Male science. Why do we do ECG? Why do we do ECG? Okay. What else? Okay. What abnormality? Hypertrophy. What else? Arrhythmias. What else? Ischemia. What else? So the reasons why we do ECG simply to determine the patient's heart rate. Is heart rate normal? Is it tachycardic? Is it bradycardic? Does the patient has arrhythmias? Is it ventricular coming from the ventricle? Or is it supraventricular coming from above the AV node? Or if there is heart block, is it sinus node block, AV block, or right bundle or left bundle branch blocks? If the patient has ischemia, if there is chamber enlargement, if there is inflammation of the heart muscle, or if there is change in the electrical axis of the heart, electrolyte imbalance, and drug effect on the patient heart. So these are the reasons why we do ECG, and this is the usefulness of the electrocardiogram. So why do we have an impulse? Anybody remember this? Answer. Okay. So this is the action potential. So simply the resting myocardial cell, the electrolytes or the charges are negative inside the cell. So once we have activation, what happens to the sodium channel? So sodium channel opens and we have fast sodium goes inside these cells and you start to have the action potential. And then as this goes along, we have the calcium flows follow the sodium, and then we have the repolarization, and the potassium goes out of the cells and we go into the repolarization phase. So these are the stages of the action potential. Stage 0, stage 1, lateral phase, and then we have the polarization. This is from the second year of this school. Right. So again, we have the electrical conduction system of the heart is made of the sinoatrial node, and then the impulses travel between both atrium. We have contraction of the atrium. SubhanAllah, a sinus node is where it's on the top of the atrium. So with the contraction comes up from the top down. So all the blood will go down to the ventricles. And then it goes to the AV nodes, bundle of Hess, both bundle branches or tendon fibers. And then we have depolarization and repolarization. So this is the wave of each heartbeat. We have the wave, the R interval, Q wave, R wave, S wave, and the T wave. So why do we have a D wave? So it's an atrial contraction. So that is represented on the ECG by D wave, right? And then when we have contraction of the ventricle, that is represented on the ECG by QRS complex, right? So the atrial relaxation is not manifested on the ECG. Why? Because it's dominated by the QRS complex. But the ventricular relaxation, we can see it by seeing what? The T wave. Okay, so the ECG wave, we have atrial contraction, and then we have the PR interval from the beginning of the D wave to the R wave. Then we have the QRS complex, then we have the ST segment, and then we have the T wave. So these are the segments of each cardiac heartbeat. All right. So how do we measure this thing? So the patient has to be connected to the ECG machine through wires, and we do have different wires. We have wires that are connected to the patient's limbs, and this is from the American College of Cardiology. And the ECG leads are really colored, or it says which limb you have to connect the patient to. So these are the limb leads. And then we have the chest lead. The chest lead is made of 6 leads. The first one is in the fourth intercostal space on the right side. Lead 2 is on the fourth intercostal space on the left side. Lead 4 is on the mid-clavicular line, fifth intercostal space. Lead 3 is in between lead 2 and 3. And 4, lead 5 was on the anterior axillary, and 6 on the mid-axillary line. Right. So in order to read the ECG, so the one reading the ECG in Mecca was the same conclusion of somebody reading the ECG in Jeddah. So we have to standardize on the paper. So if you first look at the ECG, it's made of large and small squares, right? Okay, so that helps us in measuring the chamber size and helps us in measuring the time, right? So to diagnose arrhythmias, to diagnose the heart rate, and to diagnose the schedule. So the first thing you have to look for, the first thing you have to look for is the standardization of the ECG. So this comes to the side. So this has to be 2 large squares. If it's for the 2 large squares, you will falsely overdiagnose chamber enlargement, right? And if it's smaller than 2 small squares, you will miss the diagnosis of chamber enlargement. Right? And also we have to look at the speed of the paper. So the speed of the paper has to be 25 millimeters per second. If it's slower than that, you will falsely diagnose tachycardia. If it's faster than that, you will falsely diagnose bradycardia. So each paper is made of many large and small squares. Each small square is made of 0.04 seconds, right? And each one large square is made of 0.2 seconds. When I mean each second is 5 large square, right? So if you want to multiply that by 60, so how many squares do you have? So 1 second is 5, right? So if you want to have 1 minute. What's that? 300, right? So it's 300. So this is very important to diagnose arrhythmias and to diagnose the heart. So this is the first thing you have to look at the ECG before you read the ECG, right? Okay. So the first thing when you're reading the ECG, you have to calculate the patient's heart rate. So there are three methods. This is number one. You go to both waves. If the heart rate is regular, and you measure how many large squares in between those two waves. Okay? So in this patient, how many large squares we have? 1, 2, 3, 4, 5. So 300 divided by 5 is 60? 60. 60, right. Okay, so this is very simple and straightforward. Any questions? Fahmi? So this is the most easy and straightforward. Everyone does this. The other thing is, if you are so crazy, you can measure the small squares, right? So each one of these large squares is made up of 5 small squares. So 5 by okay, so each large square is made of 1, 2, 3, 4, 5. So خمسة كم؟ 25. So okay, so this is 1,000 divided by 5. So simply, if you really that crazy, you measure how many small squares, you divide that by 1,525, then it gives you the heart rate of the patient. Nobody does this. It's easier to calculate the larger squares. Okay. How about if you have an irregular heart rate? What would you do? Yes, in 10 seconds. So how many waves in 10 seconds? So how many large square there would be in 10 seconds? In each second is 5 squares. So 50, right? So the number of R waves divided by 50, you will get the heart rate if you have an irregular heart rate. Okay, then we'll talk about the axis of the heart. What is the axis of the heart? What do you understand? Axis of the heart. Axis deviation. So the axis of the heart refers to the way the impulse travels. So normally the heart, the sinus node is here. So when you have an impulse traveling, it will go this way, right? If you have chamber enlargement, right heart enlargement, the impulse will travel this way. Why? Because you have a big chunk of muscle. If you have ventricular hypertrophy, the impulse will travel this way because you have a big chunk of muscle in the right side. This is very easy. I'll show you how we can do that. So we have lift axis deviation because of the left ventricle is really dilated. So the impulse will travel towards that higher chunk of muscles, and there are differential diagnoses: inferior line, inferior branch block, horizontal heart. And if you have right axis deviation because of a bigger right ventricle, the impulse will travel this way. And if the differential diagnosis is right ventricular hypertrophy, ventricular heart, and hypertension, and right branch block. So how do we determine the axis? We simply look into lead 1, lead 2, AVF, or any of the left leads. So if we have Creon's complex is positive in lead 1 and positive in lead 3 or AVF, and this is normal axis, right? And if you have Creon's complex, positive Creon's complex, and negative in lead 2 or AVF, then we have the axis deviation. And then when lead 1 is negative and lead 2 is positive, then we have right axis deviation, and both are negative. It's indeterminate or extreme axis deviation. Okay, so the steps of reading an ECG, you have to go through these things so you don't miss the diagnosis. So you calculate the patient rate, you calculate the patient rhythm. What do you mean by rhythm? So regular or not regular or? So regularity, this is number one. Number two? Sinus or non-sinus. So sinus, it means it's coming from where? From the sinus node. And how do we know that? Presence of B wave. So if you have a B wave, it means that B is the sinus wave. If you don't have a B wave, then it is not sinus wave, right? And then we have the corresponding axis, we determine the axis. And then we determine the intervals. We assess for presence of hypertrophy, and then we assess for the presence of infarction or speed. And we'll take examples. So we look at the ECG. So first we have to look at the patient name. We look at the date and the time, because this is very important if you have a patient coming with chest pain. And we look to the standardization. So this is 2 large squares, and the speed is 25 minutes. So this is standardized ECG. The one reading this ECG in Saudi Arabia is similar to the guy reading this ECG in right? So then we look to the standardization. So this is the standardization first. Speed. We look to the axis, so the regularity, the sinus nodes. We calculate the heart rate of the patient, E1, V2, and V1. Calculate the heart rate, assess the axis. V1 is positive, and AVF is positive, so this is not axis. Look to the calculation of the duration and intervals, the heart rate, this is very accurate. Don't read the interpretation of the ECG, because this is not always correct. Okay? So these are the steps of reading the ECG. So take examples. I need all clear from the left side. Sensaza. You said sensaza? Nothing? Right. Female side. Sensaza. And some of the ladies ECG according to the principles. Okay. So this looks regular, right? Okay. Sinus or not sinus? Why do you say sinus? It's the B wave, right? The B wave here, the B wave here, the B wave here, the B wave here. So the B wave here, right? So this is sinus rhythm, right? What's the rate? 100. Rate? Okay, so we go to this speed, we follow for the beginning of the square, right? So this is 1, 2, 3, right?
Yes.
So we have to divide by 3. So 100. But this is not 100. We do small squares here. Right. So this is 100 or less than 100, right?
Yeah.
So that's this is regular, sinus rhythm. Let's say the rate is 100. Okay? So what is the, again we go to the intervals, which is the PR interval. The normal is 3 to 5 small squares, right? And the QRS complex duration is 1 to 3 small squares. So for this patient, the PR interval is normal. The QRS complex duration is normal, right? So what is your interpretation? Sinus rhythm, so it's normal sinus rhythm. So if you do this steps, you will not miss the diagnosis, because in the examination, you are marked for each of these things. So So if you say it's normal sinus rhythm, you get like 50% of the mark. But if you see all of these steps, you will get the full mark. So this patient is 90 to 95. It's regular. B wave is normal. It's sinus rhythm. PRH is normal. This is 0.2 seconds because each small square is 0.44. PRH duration is normal. Interpretation, normal sinus rhythm. Okay? Right. That left side. This is easy.
Really come.
Okay, you get 50% of the mark.
Science.
Okay?
Science.
Sinus,
Science for the cardio.
50% of the mark. So you say sinus because it's a big wave. Is it regular or irregular? Right? It's really regular. What's the rate? 50. Wrong. So this is 1, 2, 3, 4, 5, 6, 7, 8, 8.5. So let's say 8. 300 divided by 8. Okay, so it's less than 30, right? Or around there. So this patient, you really have to learn how to do it stepwise. So rate is 30, regular, P wave is normal, PRH is normal, PRH complex duration is normal, diagnosis, sinus cardiography. So the aim is here to go through each of these steps, because each step has a mark examination and a graph. Okay, so what's the rhythm? Female. I mean the volunteer. Volunteer. Steps. So it's really regular. There's a B wave. So 150, okay? So this is the rate. It's 130 because it's more than two large squares. So this is 1 square, the second square, and then you have 2. Right? Then regular, B waves, large complex duration, normal, in diagnosis interpretation, sinus and cardio. Right? Okay. So this is easy. Any questions? Any questions? Fahmeen? Then we go to the abnormality of the D wave. D wave abnormalities, always look to that. Usually a D wave upright is only 7 beat ABR. Duration is less than 2.5 millimeters, means that is that 2.5 small squares. Amplitude is that 2.5 millimeters, which is less than 2.5 small squares. Abnormalities, if you have inverted D wave, it means that the D wave is not coming from the sinus, it's coming from somewhere else. If you have a wide D wave, more than 2.5 small squares, you diagnose with atrial enlargement. If it's deep, more than 2.5 small squares, this is pulmonary, right? If you have sawtooth appearance, this is atrial flutter. If you have absent D wave, this is atrial fibrillation. We'll take examples. So the diagnosis is here, but we need to explain it. I need somebody from the website. This is atrial fibrillation. Explain. Why do you say this is atrial fibrillation?
Absent D wave. Absent.
So irregular and absent D wave. So this is the hallmark of the diagnosis. So the rhythm is irregular. It's irregular rhythm. You don't see consistent D wave. Maybe there's a D wave here, but it's not really consistent. You don't see it with each heartbeat. So the diagnosis here is atrial fibrillation, right? So if you want to calculate the heart rate, you need to calculate the heart rate in at least 10 seconds, right? Diagnosis? Simple. Explain it. So it's really, so atrial flutter is usually regular. So those appears. Stand on the chart, sorry. Stand on the chart, just close your eyes and look at the ECG and you'll see it. So this is really regular, right? And normal complex. So the purest complex is 9. So atrial fibrillation, atrial flutter, they are the same condition. You have to treat them the same. So this rhythm is regular. Okay? Else? White? Yours complex white? That is heart rate.
Yeah.
Why?
Delay impulse.
Delay impulse. Okay. So this is the P wave, huh? This is the sinus node B wave, right? This is the same B wave, huh? Same shape, same morphology, right? But this one here is different. It's different, huh? But it's similar to this one. Huh? And the rate is faster than the normal rate. I don't know if you explain this.
Other sorts of period.
Yes, what do we call it?
Topic.
Topic? Yes, atomic atrial beat. So this is what we call premature atrial contraction. Okay, so the sinus node B dominant cell is giving you the impulses, right? Sometimes you have another cell trying to dominate, right? It gives you premature contraction. So this beat is normal, but this beat is premature. It's coming from the sinus node. It comes from a different cell. It's followed by a correspondence. It generated contraction in the atria, and also generated contraction in the atria. But it's not the same sinus node, or it's not the same cell that it is trying to right? So the rate is 70, regularity, occasional irregular, B waves. We have two different morphology. PR interval is normal except for 2 beats. PR duration is normal. Interpretation. Normal sinus rhythm with premature atrial contraction. We see this condition in patients with bronchial asthma. When they take the bronchial medication, right? Or COPD patients. So this is, what is this?
These are
These are okay. So this is normal sinus rhythm. We have an E wave, QRS complex, it's regular. Until you can see this, these are shaped QRS complex, right? And it's not preceded by B wave. So there's an atomic focus where in the ventricle, right? So it generated this speed. Usually these beats, they don't generate enough cardiac output. So that's why the patient goes into multiple beats like this following each other. We call it ventricular tachycardia. And if the patient is in ventricular tachycardia for a long time, he will die. He will arrest the die. Because there's not enough cardiac output. So simply, this is the way we have the impulse, the normal way. So impulse is there, goes to every node, and then it goes down to the ventricle. If you have this problem, beats coming from the ventricles look like activation. The activation starts from where? From the ventricles. And usually it doesn't generate enough cardiac output. So if this is prolonged, the muscle gets fatigued and patient goes into ventricular fibrillation and patient dies. Okay. So now we go to the intervals. So intervals, the normal interval is 1 to 3. When you have wide or prolonged interval more than 5 small squares, we call it AV node stop. AV shorter than 3 small squares, we call it pre-excitation. So this fast impulse traveling through the atrium into the ventricle, when we call it fast or pre-excitation, two conditions. The patient has tachycardia, high performance, or a condition called pre-excitation syndrome. And then what is more darkness or what? Accessing pathway. So accessing pathway between the atrium and the ventricle bypasses the usual. Have fun. Instead of traveling to the AVO, it goes to the accessing pathway. There is no delay. Alright, this is that corresponding duration. Normal, less than 1 to 3. If it's more than 3, then this is bundle clock with the right or left. Alright? And we'll see examples. Alright. So let's talk about a ventricle. We talk about first right ventricular enlargement, left ventricular enlargement, right ventricular hypertrophy, left ventricular hypertrophy, and how we diagnose them. So the right ventricular enlargement, we look into 2 leads. We look into lead 2. Now we're looking at the atrium. So which lead do we look into? So the B wave, right? The best leads to show B waves are B2 and B1. Right. So we are looking at the right ventricular enlargement. So what do you expect to happen in B wave? B pulmonary. So what do you expect it to be like? It's big. It's big than 2 small squares, right? So look at B wave here. It's almost like 50% of the US numbers, right? So this is more than 3 small squares. We need 2. In B1, we have 2 components. The B wave is biphasic, right? And they usually are equal. No, if you have right ventricular enlargement, the positive component represents the right atrium. So it's really more than the left atrium. So it's really slightly big, more than 1 small square in height and 1 small square in duration. Right? So the diagnosis of this patient is right atrial enlargement. But there are other things in ECG which we will talk about. Now we go and talk about the atrial enlargement. So where do you expect the changes? B wave. Okay. So how do we diagnose it? So why not B wave? More than 2.5 small square. We look at B2 and B1. So in B2, what do we see? Biphasic. Oh, sorry, different. Y more than 2.5 small squares. And in B1, the negative component is bigger than the positive component. So this is left atrial enlargement. Whatever the goes. Alright. We go to right ventricular and left ventricular. Which segment of the each we look at? So we look at the QRS complex now, right? So we look at B1, right? And B6. Alright. So the first thing we look at with this patient is B1, because B1, B2, B3, they look at the right side of the heart. Right? B4, B5, and B6 look at the left side of the heart. Alright, so the major thing to diagnose this is to look at the P wave, this is the R wave. So the R wave is bigger than the S wave, it's more than 7 millimeters in height. So if you see a tall R wave in V1, think of right atrial, so right ventricular enlargement. If you have right ventricular enlargement, what would happen to the axis of the heart? You will have right axis deviation. Look here. Look at V1. What's the axis here? Positive, negative, the dominant wave. Negative. Look at AVF. Positive. So this is right axis deviation. So right axis deviation, we have big R wave. The diagnosis here is right ventricular enlargement. So whatever reason, the most common reason would be pulmonary hypertension, pulmonary stenosis, right? So right ventricular hypertension. And also you have some STT changes on the right ventricle. So you can see ST segment depression. Okay, because the right ventricle is enlarged. The number of small vessels is not enough to supply that impulse. Okay. Questions? questions? Yeah, fine. In the left ventricle, we look at two waves. We look at the S wave in V2, V1, and we look at R wave in V4 or V6. So the summation of the small squares, it is for the 35. This is the diagnosis of the particular effect. So this is the major component of the diagnosis. It is large criteria, but this is the most important criteria. So in this patient, how many squares we have? So this is one large square, two large squares. So this is 10. في واحد هنا and one here, so this is 12. 12 large squares. And in our area B5 we have 10, 20, 25 plus 12. 27. So this is more than 25. This is the diagnosis of left ventricular hypertrophy. If you have left ventricular hypertrophy, what do you expect the axis? Left axis deviation. Look at the one positive. Look at ADF. It's negative. So this is left axis deviation. The left axis deviation, its scientific name is left anterior vesicular block. So this patient has left axis deviation and left ventricular hypertrophy. To confirm the diagnosis. Alright, now we go to the article abnormalities. Alright, so if you have some article that will be done, tactical and cardiac, something is ready. Don't be article configuration with heart block. We'll see some examples. So first the classification. We have first degree heart block, we have second degree voltage type 1, we have second degree voltage type 2, and we have third degree heart block. So this is tough to be practiced. So simply first degree heart block. What will happen to the PR interval? So there's a block. So simply you calculate from the beginning of the T wave to the start of the PR circles. The normal is 85. So this patient, let's say 1, 2, 3, 4, 5, 6, 7, 8. So this patient has heart block, right? So but this interval is consistent. It's consistent, right? So simply this is the diagnosis, so this is how first degree heart block works. Only prolongation of that.
Yeah.
Very cool. So the rate of the patient is on, beta blockers, calcium channel blockers, questions? No questions? Then we talk about second degree AV block. So second degree AV block. We have Moritz type 1 and Moritz type 2. So Moritz type 1, what happens to the PR interval? So the PR interval slightly prolongs until it becomes fatigue, and when T wave is not pulled up. So this is drop T wave. This is not the side. What do we call it? So the first peak following the drop, the PR interval is similar to the first peak before the drop. So again, it's simply the same. So we have a PR interval here, PR interval prolongs, and then the T waves come down. And this is the PR interval, it gets prolonged, and then it's come down. So the same. So this is classic model. Alright, so second degree voltage type 2, simply we have, so this is voltage type 1 and this is voltage type 2. Voltage type 2, we have closed peaks, but the PR interval here is fixed. It doesn't change. It doesn't prolong. Okay? This is more dangerous. So look at this patient, the interval is really prolonged. If you look at this peak, it's only, and this peak, and this peak, and this is not included in the exam, so the diagnosis would be first degree heart block. If you don't see this peak, right? Because the PR interval here is fixed, prolonged and fixed, right? And then it goes to one peak. if this is promotes gradually, this is maybe back and forth. But this patient has drop feet, theological is fixed. And what we call this? One statue, 2 to 1 block. 2 D waves, 1 to 1 block. 2 to 1 block, dangerous filling, patient should be treated with this. Alright. Sometimes we have high grade block. It's not typical of the second degree, not typical of the third degree, and it's bad. And in this patient we have, it's second degree block. It's 2 to 1, sometimes it goes to 3 to 1 block. Right? It's not equal. This is not equal to any dimension. Now we go to the most ominous and dangerous study, third degree heart block. So simply we have heart block number 1. And the heart rate will be slow. If you have any patient with heart block, don't expect to have heart rate of 90 or 70 or 60. The heart rate will always be this level, right? Very fast, very fast. And in the third degree heart block, there are criteria to diagnose. Number 1, we have the atrium contracting at a rate different than the rate of the ventricle. Because of the atrial block, the atrium will be faster than the ventricle. So this is number 1. Number 2, an atrium, because it has its own heart rate, there is no association. So you can have contraction of the ventricle and the atrium and contraction of the ventricle at the same time. This is what we call dissociation. And right. So to diagnose dissociation, you look at the presence of the T wave. So this is the T wave.
Yes.
So the T wave is before the QSL. That is small. And then you have T wave, and then you have T wave. And you have the long theology, right? And then you have QSL. Okay, and they say this would be basically a block or it could be many times. And then you have T wave on the top of the T wave. And then you have very long theology. And then you have T wave in between QRS complex and the T wave. Then you have T wave in between. Maybe it's the T wave. Right? So this is complete dissociation. T wave, it has its own mind. It doesn't care about it. It jumps anytime. Little contraction, full contraction, full visualization. So it is complete dissociation. So this is number 2. So number 2, what's the heart rate here? The ventricular heart rate. 1, 2, 3, 4, 5, 5.5. 300 divided by 5.5 is 160. Yes, right. What's the atrial rate? What's the rate of the atrium? Let's say, let's calculate this rate. So this is 1, 2, 3, 4. So 300 divided by 4. 7. So the atrial rate is faster, it's 7. The ventricular rate is something below 60, right? So the atrial rate is faster than the ventricular rate. You have AV dissociation, and the rhythm is very high. So this is the diagnosis and the criteria of complete heart block. We go to the right and left side of the diagram. Simply, the easiest way to look at it is an A-shaped QRS complex. So wide QRS complex and A-shaped. So if the A-shape is on V1, that is it is on the V6, this is left axis rotation. So left axis. So this is the typical right-handed branch block wave pattern. We have R-S-R pattern, and in V6 we have E-S wave. So this is the diagram. So again, what we see, if we look at, because we're looking at the right ventricle, we look at V1, V2, and V3. So you start to see R-S-R pattern, right? And your surface here is Y. So this is right bundle branch block, right? And you have some STP changes that goes with the conduction abnormalities. Right? So there's a big ROE field, but it's not right ventricular hypertrophy. Right? Right ventricular hypertrophy, you have tall out there, right? But associated with what? Medius wave and right axis deviation and double complex. This patient has wide complex, axis is low. So this is lift on the crash block, we look at D1, deep S-wave, and in-shape data in pieces. So this is the example. Deep S-wave in the D1, D2, D3, and you have the in-shape wild coils complex in D6, right? And axis in the majority is. Alright. So this patient, what does he have? He has a normal B wave, coils complex, normal beats, normal beat, and then there is nothing. Right? So we call this sinus complex. We expect to have a B wave, right? But the sinus node is not functioning. So this is what we call sinus arrest, secondary to sinus node dysfunction. We see that in elderly people when they have degeneration, calcification of their sinus node. So this is, here, what is this? This is just a rigid slide. What do you see here? Premature atrial contraction. This is the normal B wave, normal B wave, normal B wave. But we have abnormal B wave chemistry. So the rate is faster than the normal usual rate. What's this? The diagnosis is there. I need explanation. So absent B wave, you don't see B wave here, right? So it means that this rhythm is not coming from the, so this is not sinus rhythm, right? So it means that it's coming from AV node, we call it the junction. What's the QRS complex? Node, narrow QRS complex. It means that it's coming from above the his bundle. If it's below the his bundle, it would be wide QRS complex. So what we call this junctional rhythm. What's the normal rate of the AV node? 60. 4 or 60. What is this patient? 1, 2, 3, 4, 5, 6, 7. What's 300 by 7?
35.
Yeah, by 7? So this is what we expected from 40 to 60, so that's fine. But if you see something like this, absent B wave, and another curve is complex, and it's regular, but it's tachycardia, what do we call it? We call it junctional tachycardia, right? Alright, so this is more much easier. So what is this? It's a date. Yes, you're right. It's a date.
Bizarre theology.
Bizarre QRS complex.
No B wave.
Bizarre, especially at the top here. Right? No B wave and tachycardia,
Regular.
white complex. Ventricular tachycardia is always white complex. So this is regular, white complex, absent B wave. This is ventricular tachycardia. So this patient has, if you see the speeds, it's the same patient. It's already two. Ventricular tachycardia for a long time. The muscle gets fatigued and the patient goes into ventricular fibrillation. This is forced ventricular fibrillation. Okay, so this patient has ventricular tachycardia, very bizarre shape, QRS complex. This patient we call it sadly one because it's not regular. It changes its axis. So what's this? Ventricular tachycardia. So in-shape means that it's coming from this below the one of the faces, either right bundle or left bundle. And it's fast, it's regular, absent B wave, this is ventricular tachycardia. Ventricular tachycardia can be monomorphic. Morphology is the same for the monomorphic, like this patient, or it could be polymorphic ventricular tachycardia. So this is ventricular fibrillation. This patient is dead. There is no cardiac output. Right. Let's skip this slide. We'll go to the final slide for the ECG, how to diagnose myocardial infarction or myocardial disease in the ECG. You look at abnormal T waves, look at the ST segment depression or elevation, look at the deep flap or the first T wave. Right? And the diagnosis of ST elevation is by 1 or 2 millimeter in 250 dose speeds. Right. So the ST segment of the part of the ECG value is this segment. From the end, the beginning of the S wave, the S wave to the beginning of the T wave. Right. So that every ST elevation is acute myocardial infarction. Their differential diagnosis, patient with half, paracetamol angina, acute pericarditis, airway depolarization. If they have systemic depression, it's not always ischemia. You can see that the patient with ventricular strain, when they have ventricular hypertrophy, valvular hypokalemia, or the opposite effects. So the isoelectric line, we measure the SSA complex, and then what we see here, it's a second depression. What do they mean by second depression? If this patient is rustic, when we do the ECG, what's the top depression diagnosis? It's a second depression. Ischemia. So we put the patient on the treadmill, and we make it run, and we do the ECG at the same time. So what happens to this segment? This segment drops, goes to the ground. Right? So there is like 3 millimeters a second depression. 1, 2, 3. So this patient has ischemic heart disease. He has no renal vascularitis. They should go for that. Should start treatment and should go or down. Alright. So is there a way to differentiate between patient with ischemic heart disease, acute myocardial infarction, or patient with pericarditis?
Yes.
Yes. Tell me.
Pericarditis diffuse. وما تكون الباترن حق السكيميا.
So it's convex systemic elevation and diffuse or leads
No reciprocal effect.
and no reciprocal changes and
وهايبر بي.
right. You have depression, right? Sometimes it tells you how to diagnose it. And if you take the history from the patient, you'll be able to predict the change. And usually you see that the patient with connective tissue disease, chest pain is different than the patient with acute myocardial infarction. Usually they are not patients. Because treatment, it's hugely different. If you give this patient therapy accurate, the patient will bleed in the pericardium. Okay, and you will kill it. Okay, so if the patient has ischemic heart disease, previous myocardial infarction, they will have the weight because they have transmural myocardial infarction. There is a scar in the heart, there's abnormal conduction of the veins. So this patient has complete infarction. Now the pathological view is 25% of the PRS complex, and it's wider than one small square. So if you see this is pathological. It means that this patient had prior myocardial infarction. So how can you localize the site of the myocardial infarction on the ECG? Anterior wall myocardial infarction. Which artery? Right? What artery? What do we call the artery that supplies the anterior wall?
Left main heart.
Left anterior descent. Anterior wall myocardial infarction, which leads.
2 and 3 and every.
Okay, what is the artery? Lateral artery. Lateral wall. Circumference. So the anterior wall myocardial infarction, we split the C on D2 with 3 and AF, and the artery that's supplying the anterior wall to the right, so the artery in the majority of the cases. Anterior wall myocardial infarction is supplied by the LAD, this anterior descending artery, which is the major artery of the heart. So this is, they call it the widow maker. Widow maker. Sign and because this is one of the major pillars of pregnancy analysis. And we see the B1, B2, B3, and B4. And it's the electrical section. Lateral wall, you see the B5, B6, B1, and B12. And this is the part. So this is, this patient has what? Chip diagnosis.
Anterior.
So this is the wave, right? And then you are S T now on this D wave, I D wave, D wave, D wave, from V1, V2, V3, V4, V5. So this patient has extensive anterior صح?
Anterolateral.
Yes, what do you say anterolateral?
Left arm.
So 5 and 6 are involved. 5 is involved.
And there is a
You
significant back.
have systemic elevation and you have systemic elevation in each one. So this patient has anterolateral myocardial infarction. It doesn't mean that the circumference is involved. It means that sometimes we have the diagonal, which is the branch of the LED, supplying part of the lateral wall. Okay? And it's really proximal. It's before the bifurcation, before it gives you the diagonal. So it means that proximal artery, big muscle supplying that artery, huge infarction. Okay? What is this? Here, explain it. So you have this segment elevation here, 2, 3, right? Area, right? What else? When you read these things, you have to know the weight, the arrangement, the complex, the rate, the rhythm, the axis. Differential diagnosis, the spot diagnosis. This is a clear overlapping function. When you got some function, what happens to the area adjacent to it? Opposite. Reciprocal changes. You see reciprocal changes? Where? Second pressure where?
Lateral.
Lateral, yes. You see? It's the second pressure. You see the second pressure. This is reciprocal changes, right? So the meaning, I can explain to you why do you have reciprocal changes?
عشان الكاميرا من opposite side تكون معكوسة.
Explain it. Let's say this is the muscle. If when you have emphysema, one lung is diseased, what happens to the other lung? Compensate. So if you have an area that is supplied by the artery, and the artery is blue, what happens to the muscle? What happens to the muscle? So this is not contracted, the anterior muscle. Or anterior is not contracted. What happens to the muscle? It's not like this, huh? Right? So let's say the anterior is not functioning. So what happens to this one? Increase to compensate. So if you have like 20 or 30% disease, and this is contracts stronger, what happens? It becomes ischemic. So when it becomes ischemic, you start to see this is segment depression and point to several changes. So this is the scientific explanation. Okay, so this patient has this lateral function. This is elevation in 1, and 5, 4, 6. Okay, so what is this? This is the last slide. So the first thing, this is acute coronary infarction. Where is the visualization? Anterolateral. Anterolateral. Starting from where? From V2, 3, 4, 5, 6. You see it in ABL. You see it in V1. And you see reciprocal changes where? Right? So this means that this patient has diffuse coronary artery disease. The artery that is included is the anterior, but the other artery is not included. So this website is the Harvard School of Medicine website, and incident issues. If you want to go and it's practical ECGs, ECGs, we're going to take a break and then we do this. So we'll talk about etiology, coronary disease, risk factors, atherosclerosis, pathogenesis, clinical spectrum, regular presentation, investigation, acute, and treatment. So, coronary disease is unfortunately the number one cause of death in the world. And in Saudi Arabia, coronary disease has 35% of cause of death in our communities. percent particularly in traumatic accidents. So the number of people dying with ischemic heart disease is really increasing, and it's very expensive. So how does this disease start? Typically starts by causing of atherosclerosis. So atherosclerosis is a chronic progressive inflammation and fibrotic disease of the arterial wall with large and medium arteries. And it's aggravated by the factors. So all of us will have atherosclerosis. But the speed with which this disease progresses is different between one person to another person due to the presence of this factors. Now, the important thing to understand is the atheroma formation or the plaque formation. So simply this is an intimal thickening with the small muscles proliferation. So we know that the blood vessels has 3 layers: the intima, the media, and the tissue. So this is the problem of the intima. There is thickening due to small muscle proliferation. There is lipid accumulation. There is oxidation of this lipid with the more signs of cytosis. There is inflammatory cells infiltration of blood vessels, leading to progression of these atherosclerosis. Now, arteriosclerosis is different than atherosclerosis. It's only hardening of the small arteries, and arterial, you see that in patient with long-standing hypertension. All right, so this is the normal blood vessel. We have this layer called the intima. Then we have the media. Then we have the tissue. So the intima is the basement membrane of the endothelial layer, which regulates hemostasis, thrombosis, vascular tone, and irritability. Media comprises smooth muscles, which controls vascular tone, and the tissue carries the arteries of blood supply, nerve supply to that artery. So the endothelium releases mediators that can control the contraction and relaxation of the arteries. Also, it releases mediators that can prevent thrombosis of this injury. It can release mediators that can cause thrombosis to stop. So why we have chronic disease? Simply because we have these factors like hypertension, dyslipidemia, diabetes, coronary failure, smoking, bad diet, lack of exercise, increasing psychological causes, genetics, gender, age. There are other new and emerging risk factors like C-reactive proteins, calcification, homocysteine, pathology, DNE, connective tissue disease, and infection. So what are the stages of atherosclerosis? Simply, this Fertile is a very famous physiologist who really set the stage for the understanding of the pathophysiology of atherosclerosis. There are multiple stages according to the American Heart Association. We have stage 1. So this starts at a very young age. So once we start eating as babies, we start to have this oocyte adhesion migration. Then we have full cell forming, which is a macrophage containing the liver, accumulates on the intima. And then we have venous exposition of the lipids, which is this yellow bit on the wall. This actually increases, it accumulates further, and then you start to have narrowing of the blood vessels. Now this material simply, the way I look at it, it resembles Twix, I think the Twix bar. Twix bar is made of chocolate, right? What's inside the chocolate? Toffee. So the toffee for me is that negative 4. So the toffee or that negative 4 is atherogenic. So once that material is exposed to the blood vessel, you start to have proliferation. Because the platelets, they look at this as there is loss of the integrity of the wall, and this material generates the mediator that can cause thrombosis, which is stage 6. Atherosclerosis starts at a very young age with back start to have accumulation of fats. So this is the intimal layer, and this is what we call as the fibrous cap. So if this fibrous cap is mature, thick, calcified, it usually does not cause acute testisegment elevation anymore. It causes non-testisegment elevation anymore. But if it's really immature, then it's easy to rupture. When it ruptures, it releases this material into the blood vessels, and you have complete cessation of the blood vessel type. That those patients will present with acute myocardial infarction, testisegment elevation. So if you diagnose the patient at this stage, you can easily control these risk factors. You can give them statin to decrease activation of the lipid core, improve patient progression and survival. All right, so what happens when we have risk factors, when we have high lipid contents? So this will lead to increased activation of endothelial cells, increases the ability to back cholesterol, adhesions to monocytes. Monocyte goes inside the intima. This is the fat goes inside the intimal layer, becomes oxidized, taken up by the macrophages. Macrophages accumulate and forms that yellow lipid core, and then you start to have release of the cytokines and inflammation. So with further inflammation, you have more bone cells, more lipids, more collagen, more smooth muscles, more macrophages, high cholesterol. Then you start to have lymphocyte infiltration, and then you start to have cell death, more release of mediators, more atherosclerosis, and this becomes weak at the hinge points, which is the weakest area. And then you start to have release of this material into the blood vessels, and then you start activation of the platelets, aggregation of the platelets, and thrombus formation. So we look at the blood vessels. So this is the blood vessels, just like a urine. So we have 50% occlusion. So you have this material going into the blood vessels, decreasing the blood going through. But those patients will remain asymptomatic unless they exercise. And then you start to have symptoms. When you look at patients with more accumulation of this material, which will be like 95%, those patients have symptoms, restless. So when we do an angiogram, which we take a patient with a cath lab, so this is the catheter, this is the artery filled with blood vessels. You see this number, right? So the narrow is probably like 50%. Okay, but when we put a wire and we do something called intravascular ultrasound, we can see the actual clot. So this is the lumen is this is the normal lumen. This lumen is filled with this white material, which is the lipid core, which is the black formation inside the blood vessel. Which is another look at the blood vessel like this. And this one is the blood vessel from outside. It's a nucleogram. Okay, so this is the normal blood vessels. So this is the lipid inside the wall of the artery. So in the beginning, we have something called positive pneumonia. This material, or this space, will be taken out by the lipid core. And then when this space actually ends, if there's no space for this lipid to accumulate, the lipid will push the lumen inside and you start to have permeable blood vessels. And when this becomes weak and ruptures, you start to have inflammation, and the patient will start to have acute myocardial infarction. So this is the lumen, and this is the lipid material, and this is the lumen rupture, and then you start to have fluid of the blood vessel. So this is thrombus formation inside the blood vessels. So that means that this patient has complete cessation of blood inside. So how does this process start? Simply start with progressive development of cardiovascular disease. Patients start to have risk factors. They have endothelial dysfunction. Patients start to have symptoms of exercise. We do cath, we see that this is abnormal, that there is abnormal tone of the blood vessels. Then you start to have atherosclerosis, coronary artery disease, myocardial ischemia, coronary thrombosis, myocardial infarction. We have myocardial infarction, we have death of the myocardial. Patient starts to have heart failure. There is scarring on the ventricle. Start to have arrhythmias. There is remodeling and change the shape of the of the ventricle. You have to treat for dilatation, congestive heart failure, end-stage heart failure, and of course, so what's the spectrum of coronary artery disease? Simply, it's a chronic disease. The disease typically cycles in and out of clinically defined phases. We have patients about middle-aged person, above the age of 40, Alzheimer's factors, obesity, lack of exercise. Those are basic complications. But then with the more diseases include stable angina. So stable angina, patient goes like exercise for he walks for 1 kilometer, then he starts to have chest pain. So this is stable angina, and it's predictable at the level of exercise. And then the patient starts to have progressive angina. So there's significant number of this coronary artery, inflammation, and very vulnerable. Patients start to have symptoms, this and this exercise symptoms present. So those patients that really high risk patients acute require disruption, anesthetic angina, or non-fluid line, or so the spectrum of disease, we have basic patient, we have stable angina, we have unstable angina, then we have non-necessary elevation by cardiac infarction, and we have disease occluded in the blood vessel. So the acute syndrome, we have progressive chest pain, no evidence of myocardial necrosis and stable angina. So we have chest pain, this and this exercise, with progressive chest pain, no evidence of myocardial necrosis. It means that we do troponin, test will be negative, and we will have moderate narrowing of the blood vessel, in the heart lab. Treatment is aspirin, beta blocker, ACE inhibitors, and statin. Statin, very important conversation. And then with non-necessary elevation by cardiac infarction, you have progressive chest pain with evidence of myocardial necrosis. We do troponin tests or cardiac enzyme positive, it means that necrosis of the myocardium. If we do ECG, typically it doesn't show necessary elevation of changes, or you can see S segment depression. And usually they have moderate to severe development. Now the killer is acute cardiac infarction. We have complete occlusion of the artery, progressive chest pain at rest, with myocardial necrosis, positive troponin, and we have S segment elevation for new intervention. So this is the spectrum of acute coronary syndrome. Anesthetic angina, second elevation of the heart, second elevation by cardiac infarction. The spectrum of coronary artery disease is from asymptomatic patient into the so what's angina? It's pain or discomfort in the chest or the basic areas caused by insufficient blood flow to the heart muscle. To diagnose that, we have to have 3 characteristics. So if we have chest pain, this chest pain has to be retrospinal area, radiated to the neck or the arm. Worse with exertion and stress, and relieved by rest or neck. So if we have these 3 characteristics, then we call this patient typical chest pain. If we have only 2, we call it atypical. If we have only 1 of these, we call it non-cardiac chest pain. So this is very helpful when you see a patient with emergency departments. Now, clinical classification, we have critical angina, we have atypical, and we have non-cardiac chest pain. So this is a very important slide. If you understand this slide, you understand everything about that coronary artery disease. So what happens when we have this? We have to have oxygen supply, and we have oxygen demand. Right? So if you understand this, you understand how to do those patients. So simply there is an imbalance between the supply and the oxygen demand. So the oxygen demand, which is the oxygen, the amount of oxygen the muscle needs, is dependent on contractility. So we have strong contraction, right? We need more oxygen, right? If you have faster heart rate, if you have tachycardia, if you are exercising, we need more oxygen. If you have high blood pressure, we need more oxygen. Right? And there is something called coordination. Coordination is simply the action of the afterwards. So if your afterload is high, then the muscle will need more oxygen. Okay? So this is number one. This is the myocardial oxygen demand. Then what is oxygen supply? What is the oxygen? What is the determinant of oxygen supply to the muscle? The number one determinant. What's the vehicle that supplies?
Block.
So the oxygen supply is determined by the coronary artery, right? So there's something called perfusion pressure that you have to understand. There is some inherent and physiological changes that can happen in the coronary artery. But there are obstructions. You have obstruction of the coronary artery, then you have increased supply. Obstruction can be seen by what?
Atherosclerosis,
Sclerosis,
thrombus,
embolus, or spasm.
spasms.
So if the patient has chronic obstruction, then there is some of them may have collaterals and spasm, right? And there's something called diastolic flow. So this is very important to understand. Diastolic flow. So we know that we have systolic contraction of the ventricle and relaxation. So the supply of blood or oxygen to the heart during diastolic phase. Right? So this is easy to understand, but it's not always because there's some flow of blood, especially on the right side. There is. Right. What other things that determine oxygen supply? So this is the body that supplies the oxygen and blood. What is the other things?
Oxygen saturation. Oxygen saturation.
Oxygen saturation, oxygen. So if your oxygen is high, that's why if you're hypoxic, then you are ischemic, right? What else? Hemoglobin, anemia, right? So oxygen supply and hemoglobin, iron, or iron. So if you understand the slides, you'll be able to increase patient ischemic anemia, right? So if you have patients with tachycardia, how will you treat tachycardia? Beta blocker plus blocker, right? If you have patient with high contractility, what will you give? Actually, contractility is a strong contractility. You give beta blocker, you give calcium channel blocker, right? But you don't give digoxin. Digoxin increases your contractility. It's very bad for patient. If you have a patient with bradycardia, what will you give? If you have a patient with bradycardia, high blood pressure, you need to lower the high blood pressure. You taste inhibitor, and if you have a patient with low blood pressure, give wall tension, the best treatment for wall tension is ACE inhibitors. Okay, you have patient hypoxic, you give them oxygen, patient with hemoglobin of 4, you give them blood transfusion, low iron, you give iron. Now, if you have coronary disease with spasm, that is the stream or calcium channel blockers. If you have obstruction by plaque, what do you give?
Anticoagulation.
You give statin, right? Right? Statin. So this is the need of coronary. Right, so what is the ischemic capacity? So when the patient comes with coronary disease, they present with what? Chest pain. So this is the tip of the iceberg. You have chest pain, and before they go to that stage, there's a host of things that happen before the patient manifests. Simply, you have ischemia, you have radicals and waste products accumulation. This will lead to perfusion defects in the immune scan. Then you have diastolic dysfunction, which is abnormal relaxation of the ventricle. Then you have systolic dysfunction, regional motion abnormality, ejection fraction will drop. And then the patient starts to have ECG changes. And then at the end you have the chest pain. So the Canadian Cardiovascular Society made a scale of angina nodes, CCS angina class. Class 1,
That's 1, 2, 3, 4.
Class 4.
Yes.
It's very simple. Easy to do. You have to Royal College examination. Simple. Enough simple. So remember, class 1 angina, if you tell me that this patient has class 1 angina, it means that this patient exercises, he does serious exercise for long, but he has chest pain. It's different than a patient who has chest pain, class 4, which is class 4 angina progresses. So before, instead of saying this patient has chest pain, when he drives his car, when he goes 3 flights of stairs, you tell me it's class 4. I know what you mean. So this is the scientific language. So in the executive history, you've seen it always classified chest pain according to this classification. We have another classification which is really important. We have an association. So class 1, class 2, class 3, class 4. So these are not sufficient. So we tell this patient has class 2 angina, class 3 medical association, I know what to do. Okay, so what's saying angina? It's exertional. There's something called latent or principal angina.
Vasospasm. Vasospasm.
And spasm.
Young age. Young age.
ST elevation.
With ST elevation. Transient ST elevation.
Transient ST elevation. We see it, when do we see it?
In young age.
Young age,
Smokers.
female,
Smoker.
obese, uncontrolled. So this is the way we see this. Angina, sometimes you have angina equivalent syndrome. What is angina equivalent syndrome? Sometimes they don't have shorts. Because they have diabetic, long time, they don't have chest pain. Abnormal perception of chest. We have shorts of breath. We call it angina. What is syndrome X? Stable angina.
Silent angina. Abnormal ECG without symptomatic.
So they do have symptoms.
Yes, but abnormal ECG.
Normal ECG means stress test is abnormal. You take it to the cath lab, what happens there is normal. So chest pain, usually female, obese, usually ECG is abnormal, you look at the stress tendon, it's abnormal, take it to the cath lab, it's endothelial dysfunction. Your microvascular. Silent ischemia. What is silent ischemia? Symptoms, ECG changes. Very diabetic, elderly, high pressure. People with this syndrome. So the patient is lying flat. So when they lie flat, they have very bad skin disease. That's what angina. You see that all the patient is severe. I want to do verification. So the blood pressure, you will drop in your sleep, and then that blood pressure will be low. Right. So what's angina? Guys, I got the worst chest pain, minimal treasure press. There's ulcerated abdomen, no inflammation, there's decreased blood flow. When you have this kind of inflammation, it will be dissolved and it goes into the small blood vessels. And if you lose the small blood vessels, the patient starts to have pulmonary elevation. So these are the causes of anastomotic angina. We have diabetic obstruction, we have secondary unstable angina due to increased myocardial demand, we have inflammation, we have progression of peritoneal obstruction, we have non-occlusive thrombus pre-existing plaque. So unstable angina, so it's usually diagnosis, it has to be recent onset angina. So recent onset angina is that 1 month, increase in frequency and duration, angina at rest, it's not responding to therapy. If the pain is more than 20 minutes, 30 minutes, then this is the pediatrics. Always advise the patient to come to the hospital and see. Sometimes it can progress easily to myocardial infarction. There's mental angina spasm, large arteries, transferable ischemia, transient is the second unavailable, what is motor monitor, and 24-hour ECG, patient with jihaz exercises, and we can see that diagnose the ECG changes, or exercise testing. Now, how does the patient with acute coronary syndrome present? Simply they present with chest pain, persistence, associated with nausea and vomiting. Why do they have nausea and vomiting? Vagal effects. They have shortness of breath because they have pulmonary edema, they have sweating. But there are some atypical presentations like syncope, right? They have syncope because of hypotension or because of arrhythmias. They can have heart failure, they don't have chest pain, they have shortness of breath, and they miss the chance and they come late. Or they can have stroke because they have myocardial infarction, left ventricular dysfunction, blood formation inside the left ventricle, one dissolved close to the brain. Following surgery, the patient is in a lot of medication, morphine, Valium, he doesn't complain of chest pain, he starts to be confused, think of myocardial infarction. Or they can have peripheral embolization associated with atrial fibrillation. So when you see a patient like this and you are sitting in the ER, coming with chest pain, severe chest pain, patient is clear, you have to do a quick history. Ask about this symptoms, when the pain started. Look at the risk factors. Does the patient have prior myocardial infarction? And also, does the patient have contraindication to thrombolytic therapy? Because until recently, the treatment in my hospital was thrombolytic therapy. Right? Because thrombolytic therapy, if there's contraindication, you can kill the patient. So when you do a physical examination, this physical examination has to be focused, targeted physical examination, because the patient came with clinical emergency. You have to diagnose him and start treatment as quick as possible. Because your enemy in this patient is time. This, so we have myocardial infarction, and after it's good for 20 minutes, you start to have necrosis, cell death, and the infarct will expand, and that is transmitted into very poor particular functions, arrhythmias, and death. So you really have to concentrate on the blood pressure, heart rate, respiratory rate, oxygen saturation. What's the volume status of the patient? Is he in heart failure? Is he JDB? Is he elevated? Is he having edema? Does he have crackles in his lungs? Then it's contained for reputation, for pulmonary edema. Now, in the patient with ischemic heart disease, the signs of ischemic heart disease when you auscultate is presence of S4 due to diastolic dysfunction, or S3 if it is heart failure, associated murmurs, especially mitral regurgitation, from mobility muscle dysfunction, ischemia, pericardial valve, you can hear this is late, pericardial valve, due to pericarditis. And sometimes we have abnormal splitting of the second heart sound, reverse splitting of the second heart sounds from different branch valve. So when you do your examination, you have to be very assist the patient in order to function. You don't have to do brain examination. Make sure that the patient is conscious or healthy, or if you call it steps. Because your treatment will cause what? Stroke or intracerebral bleeding. Obtain ECG within 10 minutes of the patient leaving the emergency department. So your diagnosis is there. It's the ECG. You do the ECG, you know what's the diagnosis. Right? You don't wait for 3 or 4 hours to do the ECG. Until late your examination history while they are doing the ECG. So when the patient comes with chest pain or an emergency, everybody is there. The nurses, the physicians, the ECG is done, patient being examined. So remember that myocardial infarction means that it's complete occlusion of the blood vessels, is myocardial necrosis, lung dysfunction, and heart failure and subsequently death. Now, what are the conditions that involve or exacerbate ischemia? Simply, there's increased oxygen demand due to hyperthermia, fever, hyperthyroidism, cocaine use, hypertension, anxiety, maybe disturbance on cardiac like hypertrophic cardiomyopathy or stenosis, dilated cardiomyopathy, tachycardia, ventricular, or supraventricular. These are conditions that increase your oxygen demand. Things that can increase your oxygen demand like anemia, hypoxemia, whatever reason, anemia, cell dysfunction, autoimmunity, cocaine use, polycythemia, necrosis, cardiac stenosis, and hypertrophic cardiomyopathy. So we're seeing the patient have to take with these things, are they associated with the patient? Because if you have a patient with anemia, that's why I call it a function, you cannot give him with therapy because hemoglobin is 5. If he bleeds, he's dead. That's hemoglobin. So we're seeing the patient with acute chest pain. Think of the nice pregnant condition. This could be a second elevation of why, but it could be something else. So I want to this section and present the severe chest pain close to the back. If you get from this patient, you are done. How would you make it the difference?
Just X-ray. Just X-ray, radio delay. Pulse. Radio delay.
You should get that pressure in this arm. You should get that pressure in this arm. If there's a difference, think of dissection. I want you to dissection. It doesn't take time. Just 1 minute. If you less than a minute, you will make that. You don't have to make an X-ray. The X-ray will take like half an hour to 1 hour to do the X-ray. The liver embolism, if you go to the liver family, you'll be probably fine. Bedford ulcer, tension in the third. So these are life-threatening conditions. You really have to make sure to diagnose it, especially organ dissection. Bedford ulcer, tension in the third. Other liver curves like pericarditis, Gallagher syndrome, ventricular, pleurisy, hyperkalemia, some diaphragmatic phenomena. But these are, the history will be a little different. The basic will be. So we are evaluating the patient angina. We have to take the history. Looking at the symptoms, also the symptoms, looking at exercise, associated with factors, looking at examination. We look for all motion abnormalities. We assess reduction in the LV ejection fraction. And this is the way we do it. So this is a picture for the and then we look at causation. Catheterization are really indicating the patient is suspected of having multiple disease to determine what is the best treatment for this patient. Is it cabbage or is it just, yes, according to the disease. And then we'll now go out to disease equation with chest pain. Sometimes we have a patient with chest pain. We do this first test. We're not sure. We do my cardio, we're not sure. We end up sending the patient to the cath lab, and then it turns out that they have no. So this is the way we do it. We go from the femoral artery, we look at our wires and catheters, and it goes inside the aortic root, and then we inject contrast into the artery to take different views and we diagnose the disease. Unfortunately, this is still rich. So this is the catheter, this is the contrast, this is the left anterior descending artery, and you can clearly see there is so this is very easy fix. Just simple one stent, patient problem. Okay, so this is the patient actually I did here in 2011. Came with femoral cardiac infarction. I included right coronary artery. Anyway, we stented his right coronary artery. This is the stent. So this is occluded artery, right coronary. I think this should show the wire. So this is the wire, the balloon, stent there. This is the final result. Look how big is that wire. Alright, so this is the way we diagnose ECG, echo, PET, cardiac CT, angiogram, coronary angiogram, and intravascular arteries. So the treatment goal in the patient angina, relieve the symptoms for the patient to feel better through their exercises, improve their survival, and in general, these are the way we treat them. Lifestyle changes, risk factors control, include the hypertension, the diabetes, the cholesterol, their weight, the little exercise. Then we start giving medication, aspirin, tablets, statin, beta blocker, ACE inhibitors. Then if the patient is not doing well, we send them for coronary angiography. If a simple straightforward disease, we try to put stents. When it's really bad, we confuse disease, we send the patient for cabbage. Okay, so this is the first part.
we'll talk about the spectrum of disease, we'll talk about the evaluation of the chest pain, differential diagnosis of the chest pain, treatment area, and we'll talk about the sleep data. Talk about the causes, talk about the spectrum, and we'll talk about quickly
What is the second elevation?
so patients with emergency, they have spectrum.
If they present with chest pain to the emergency department.
This could be unstable angina and then spend the difference between them is
Cardiac results.
you understand me? They have also reported second elevation and this category difference is the second elevation. So in the States, it's 2/3, 1/3. In Saudi Arabia, this is a large registry running more than 5,000 patients. Dr. Khalid Habib, who is the president of the Sharia Heart Association, did this like 2 years back. Our representative from the National Hospital is 60% anesthetic, 40% anesthetic. Again, we talk about these things. Skip them. So the treatment goals, we talk about them. And then what about the life changing? So your target blood pressure should be this down. 140, 90. Diabetes A1C should be 7. You should stop smoking, lose weight, exercise regularly, and healthy diet. Remember aspirin, Lavix. Now we have new agents like aspirin, better than aspirin, we use in combination, especially when we put stents. Something called ticagrelor. Another antiplatelet is called prasugrel, and there is an IV antiplatelet for 2E3A inhibitors. Patients should be on beta blockers. Different beta blockers, bisoprolol, metoprolol, nitrates to dilate the blood vessels, calcium channel blockers. Remember to only use them in patients with normal left ventricular ejection fraction because they are absolutely contraindicated in patients with low ejection fraction. I've seen consultant using this medication in patients with low ejection fraction. Statins, simvastatin, atorvastatin, and rosuvastatin should be given to those patients. And ACE inhibitors, especially if the patient has hypertension, CHF, and diabetes. Now, if the patient presents acutely to the hospital with chest pain, give them heparin or aspirin or Enviranox. If the patient presents with ST2 elevation in mind, give them test. So this is the mechanism how to make this work. There's a very strong evidence to support the use in ischemic heart disease, but side effects is bleeding, Gray syndrome with aspirin, tinnitus, neutropenia with clobidine, which is being taken out of the market, and darkness can cause further. So the activation what happens when you have activation, the platelets will go and become activated by the nitric oxide and the prostacyclin, and you start to have this platelet adhere to the area of injury or the area of collapse or rupture. And then you start to have thromboxane A2, adenosine diphosphate, fibrinogen, overdrive fracture, which is just a blue, so this platelets will attach to each other. And then you start to have more platelets, more release of mediators. So if you take aspirin, you will stop this. If you give Lavix, you will stop this. If you give 2-3 inhibitors, you give enoxaparin, you will stop this. So the overdrive factor is just like glue for these platelets to be attached to the area of activation of that rupture. You have more release of lateral receptors unblocked, more release of thromboxane, A2, and adenosine diphosphate. So these are the areas where aspirin works here, 2-3 inhibitors works here, Lavix works here, aspirin works here. So we give those medications to patients with active thrombosis, you will hit all areas of possible injury. Remember, heparin blocks thrombin and factor 10 by facilitating binding to antithrombin 3. So this is heparin, antithrombin 3 thrombin, and factor 10. You have enoxaparin, which is part of the heparin. more active role on the activated factor 10, less activity on the non-drug. And then we have the conduct variables, which is mainly anti-factor 10. This is the coagulation cascade. This is where heparin works. Activation factor 10 and non-drug. This is where enoxaparin works, maybe alternative and slightly on factor 10. And conduct variables exclusively works on the factor 10. Right? This is very important execute. Analytics work where we find it. So nitrates reduces myocardial demand, dilates the blood vessels, reduces venous return, but it does not improve survival of those patients. It improves symptoms. Right? Side effects, remember it can cause bad headache and hypertension. So when you give it to the patient, especially sublingually, you ask the patient to sit down, especially elderly patients. You take them sublingually, fast absorption, hypertension, dizziness, they fall, injury to the head. So again, problem, if you use it for a long time, it loses its activity, if it's exposed to the light, it loses its activity, and it does not improve survival. Beta blockers, decreases mortality, improves survival, increases myocardial function. Reduces myocardial oxygen demand by slowing the heart rate. It actually improves contraction, but it decreases the blood pressure. It has to be beta-1 selective. Example, atenolol, cabolol, xabolol, albuterol. If you have a patient with heart failure, then atenolol is not approved for patient with heart failure, only this medication. The best drug in heart failure is atenolol. Contraindication, patient with pulmonary edema, chronic heart failure, patient with chronic asthma, chronic cardiac block, and peripheral disease. Side effects, bronchospasm, heart failure, depression, AV block, exacerbation of coagulation, and it might mask hyperglycemia in patients with diabetes. Never stop beta blocker suddenly. If you stop beta blocker, this will precipitate tachycardia, angina, myocardial infarction. So when you try to stop them like this. Okay? Calcium channel blockers, because they have the same effect of beta blockers, but should not be used in patients with heart failure. Right? Okay. So they are considered as secondary agents. Has been used cautiously in patients with ventricular dysfunction. Major problems with this medication is constipation and edema. We have many patients that don't tolerate calcium channel blockers, become swollen legs, and they think of that they went into heart failure, they do the echo, they have normal LV function, you stop the medication, edema subsides. So when you try to use the drug selection, it actually have to know the patient's history. Does he have bronchial asthma? So I can't use beta blockers. Does the patient has coagulation? I can't use beta blocker. Does the patient has heart failure? I can't use calcium channel. So we really have to know the patient very. We can't combine beta blocker and calcium channel blocker, but you have to be very careful because those medications, you give them together, it can go with the heart failure. The patient becomes severe symptomatic. Right. So if you have a patient with one or two vessel disease in the coronary arteries with normal ventricular function, they are better served with stent. If you have three vessel disease, wide area ischemia, ventricular dysfunction, diabetes, the best outcome of those patients is catheterization. So for the long-term treatment, they have to be on antiplatelets, they have to be on aspirin. If they come acutely, you have to keep them on heparin, and you have to put them on antibiotics if they are intolerant to aspirin. Remember, this medication improves survival in patients with ischemic heart disease, ACE inhibitors, ARBs, like losartan, statins, and good glucose control. Statin decreases mortality by 16% when you give it to a high dose 80 milligrams of atorvastatin. Now, in STEMI, when a patient comes to the emergency department with chest pain, and you make the diagnosis with ECG, you have to start taking vitamins. Give aspirin, 325, the patient has to chew that. Give nitrates to relieve the pain and improve the spasm. Give oxygen, give morphine. So the patient gets in the hospital, that's because that he knows that he has STEMI pain. So give him morphine, degenerative morphine. Right? So we call it Mona D. Morphine, oxygen, nitrates, aspirin, and beta blockers. If the patient is not in heart failure, if it is not hypertensive, if there is no significant burden. And if you make the diagnosis and you don't have cath lab, you have to give therapeutic therapy within 30 minutes of the patient coming to the hospital. If you have cath lab, you send the patient to cath lab immediately and go to the balloon line to be stand. Other medication that should be given, heparin or enoxaparin or chlorpheniramine. If clopidogrel, loading those 300 milligrams of the patient is like 75 years of age. Or give prasugrel and start to give the heparin in the emergency department. So if you have therapeutic therapy, start giving therapeutic therapy as soon as you make the diagnosis, you find it with no contraindications. So these are the absolute contraindications in terms of use. So, prior intracranial hemorrhage, non-structural cerebrovascular lesion, bacteriovenous confirmation, non-malignant intracranial neoplasm, ischemic stroke within 3 months, suspected aortic dissection, active bleeding, significant closed head or facial trauma. So these are absolute contraindications. You have to know this. Now, there are other contraindications like pregnancy, active ulcer disease, menses, bleeding in the last 2 to 3 weeks, high blood pressure over 190. These are not the contraindications. So before you give this medication, talk to your senior, talk to the cardiologist. Lower the blood pressure by giving bleeding drugs. So this patient came with right coronary artery occlusion, went to the cath lab with stents. Right? He was treated. So this is balloon angioplasty. And now it's not called angioplasty, it's called percutaneous coronary intervention, PCI. So the aim is, this is the artery, this is the contrast, the white thing, and the artery is not really perfused by blood. So this is thrombolysis in myocardial infarction flow is zero. There is no blood flow. Here there is slight penetration. Here there is distal opacification of sluggish flow. This is normal. So if the patient presents with TEMI1 and TEMI4, their mortality is almost 9%. So if you open the artery and achieve normal flow, the mortality goes down from 9 to almost 4%. So this patient, this is the contrast. It's going into that artery, the left main, and there is a left circumference. You see it? It's full of contrast. And you see that black thing here? This is what we call myocardial flush. Right? Because the small blood vessels are really open and full of contrast. But the problem is not here. The problem is in this artery. This artery. Very sluggish flow. Very sluggish flow. And you don't see that flush because there is a lesion here and the small blood vessels are full of clots. So the contrast does not fill up the small blood vessels. Right? This is very low penetration of the blood into the small blood vessels. So what this is normal, but this is really abnormal. Why? Because the blood is dissolved and into the small blood vessels. So the muscle is open, the artery is open, but the muscle is closed. Right? So the way we treat this before we put the stent, we put something called convective device. So why do we do ECI, interventional intervention, less invasive than surgery, fast compared to surgery, no preventive use is a must in the majority of those patients. Future need for second procedure is really higher than CABG. CABG is very invasive, it takes a long time, there is no preventive use is a must. Future need for second procedure is very low. It's really invasive, longer time to recovery, and better survival of diabetic patients. So this is the way they do CABG. They actually wrap over the chest. They break the sternum, and we open the heart, and we take the grafts for the legs, to open the general vessel. And this is the bypass machine. So the patient blood goes from his body, goes to this machine, oxygenated, goes back to the patient. And we use tons of heparin, and 25,000 liters of heparin. This is the scar post surgery. This is sternotomy scar, and this is thoracotomy scar. This is very invasive bypass surgery. All right. So the way they do it, they take the grafts into the, this is the thoracic artery, this is an arterial graft, and this one is the venous graft. They take it from the neck, they reverse it, and then they insert it into the vein. Why they insert it into the vein? Because of the valve. Complication of CABG, death, bleeding, myocardial infarction, shock, heart failure, stroke, ventricular sepsis, or arrhythmias. So now, I think we know everything about the Any questions? Any questions? Second? عشان العشرة يعني مستني half that. 5 minutes break, then we can have it. You want to take 5 minutes, you want to mortality is very high among those patients. So what's the definition of heart failure? It's a state, it's a pathophysiological state in which the heart, by an abnormality in the cardiac function, whether detectable or not detectable, fails to pump blood at the rate, commensurate with the requirements of the metabolized tissue, and only pumps at the expense of a very high elevated diastolic pressure. Simply the heart does not pump enough blood to requirements. So heart failure is simply the disease of elderly. As we become older, the disease becomes more manifested. And it's a very expensive disease all over the world. So now the stages of heart failure, there are 2 stages. There is the American College of Cardiology classification, stage A, B, C, and D, and or the functional assessment, which is the New York Heart Association functional class. So we know that class 1, class 2, class 3, class 4, shortness of breath at rest, class 1 is with extraneous physiology. So this is the functional classification, and this is the American College of Cardiology classification. So stage A refers to patients at high risk of heart failure, patients with risk factors, diabetes, hypertension, dyslipidemia, obesity, they are classified as stage 1. Those patients likely to develop heart failure. Stage B, patient with structural heart disease but no symptoms, likely have multiple regurgitation, stenosis, cardiomyopathy, the ejection fraction is normal, they don't have symptoms of heart failure. Stage C, patients with structural heart disease, but they have symptoms of heart failure currently or before. Stage D are patients with risk factors, symptoms of heart failure requiring specific intervention. They are very advanced heart failure patients. They are on iron cords, they have assistive devices, they are in hospital, they are waiting for heart transplantation. So the other classification of heart failure is whether it's systolic or whether it's diastolic. Systolic refers to the pumping function of the heart. Diastolic refers to the relaxation of the heart. Simply, we have systolic heart failure, we have a weak pump, ejection fraction is at 50%, and about 50% of patients heart failure, they have systolic risk. Diastolic heart failure is abnormal filtration. example, you have two things. You have a small balloon, it's easy to inflate. You have a plastic balloon, like one, it's difficult to put it up in air. So that's the first thing that's called heart failure because you have a very thick muscle. Right, so let's skip this slide. Let's skip this slide as well. So now, the first question you need to ask yourself when you see a patient with heart failure, why does this patient have heart failure? Right. So this would be systolic, acute, or high output heart failure. And then the other question is why now? So if the patient is having systolic heart failure, then probably he is having heart failure now because he has acute myocardial infarction, ischemic heart disease, or he has alcoholic cardiomyopathy, or he has diabetic cardiomyopathy, cocaine-induced, drug-induced, like chemotherapy, or idiopathic following viral infection, or pericarditis in a patient who is pregnant, or myocarditis following infection, or patient with terminal valvular heart disease, or pulmonary hypertension, or congenital defects. Diastolic heart failure in patients with severe hypertension. The patient has normal ejection fraction, they have very high blood pressure, long-standing hypertension, the muscle is really thick, so the blood coming from the lungs is not able to flow blood. Or the patient has severe aortic stenosis. We have aortic stenosis, what happens to the left ventricle? We have left ventricular hypertrophy, it becomes thick. Hypertrophic cardiomyopathy, thick muscle because of congenital or genetic abnormalities. Restricted cardiomyopathy, ischemic heart disease. We have ischemic heart disease and acute ischemia. The muscle becomes stiff, it doesn't relax. So, because there's no enough blood supplying that muscle. So in high output heart failure, this is the patient with acute manual regurgitation, aortic regurgitation, ruptured valves, infective endocarditis, or acute myocardial infarction. So this is why this patient is having this myocardial infarction. Now, high output, we see that in patient with anemia, every fistula, patient with renal dialysis, very heart disease, diabetes disease, pregnancy, glomerular nephritis, polycythemia, obesity, and carcinoma syndrome. So these are why this patient is having heart failure. Now, the second question is why this patient is presenting now. So this would be patients don't have heart failure, but not taking medication, is not compliant to salt and water restriction. It is new medication, especially non-steroidals or antihistamine. This patient has arrhythmias, like atrial fibrillation, or he has infection with pneumonia, or he has anemia, he's bleeding, he has hepatocytosis, or the patient is pregnant, or the patient has pulmonary embolism, or the patient under lots of emotional stresses, or there's cardiac inflammation or infection. So these are the questions that we have to think of to find an answer when seeing a patient with acute decompensated heart failure. So what's the physiology? This is again an important slide. So you have myocardial dysfunction, so the muscle does not really contract normally for whatever reason. So what happens after that? You start to have reduction in cardiac output. So the muscle does not give enough output. So what happens next? You start to have sympathetic activity, activation, more catecholamines, to compensate because the muscle is not contract normal. So the catecholamines will be higher, will be more force contraction, and faster heart rate. This will lead to increasing the rates of the heart muscle contraction and increasing the strength of the myocardial contraction itself, increasing your contractility. So if you have ischemia and this state happens, what happens? Increased cardiac workload, more myocardial dysfunction, it creates a vicious cycle, right? Again, this did not stop here. What happens then? We have sympathetic activity, we have increased catecholamines. What happens to the blood vessels? Vasoconstriction. You have increased venous return. You have edema formation. When you have cardiac output low, the blood going to the kidneys becomes less than decreased kidney perfusion. You have renin release. You have angiotensin release. You have aldosterone release. This will lead to more salt and water retention. vasoconstriction, and polypopulation. Right? So if we look at this slide, how can we treat this? All right, so we give diuretics to control edema, sodium and water retention. Okay? We give angiotensin to, okay, ARB or ACE inhibitors for vasoconstriction, the renal release, and angiotensin release. We give spironolactone to block progesterone activation. And we give diuretics. We give digoxin to build growth contractility. So this is the way we treat patients. This is one slide, physiology and treatment. Digoxin, beta blockers, ACE inhibitors, ARB, aldosterone, and diuretics. One group of medications here is the nitrates and as well as some patients contraindicated with beta blockers or ACE inhibitors. We give them nitrates and so with all kind of water we don't take the only kind of water we take is amlodipine, because it does not produce cardiac output. Okay? That's what we do with heart failure. We get combination hydrolysine because it's a vasodilator, and we get nitrate because it decreases venous return. Right. So when you have myocardial infarction, you have ischemia, muscle expansion of the myocardial infarction, death of the myocyte, there is change of the left ventricular geometry, there is scar formation. So this area does not contract, does not contribute to the ejection fraction. So this is again a very interesting slide. We have myocardial infarction, what happens? You have decrease in tachycardia, which is norepinephrine, right? So norepinephrine will go to the myocyte, go to the beta-1 receptors and eats up the beta receptors, right? So the patient will really deteriorate, will have reduced contractility, right? When we give beta blockers, what we do, the beta blockers will competitively inhibit those norepinephrine, and it will upregulate the receptors. The patients will improve, right? So if you have a patient with heart failure, for a very long time, right? And then somebody smart says, okay, stop it. What will happen? They will deteriorate. Why? Because you don't have beta blockers. To competitively inhibit the norepinephrine, you have receptors open. This norepinephrine goes down and then it leads to deterioration of the patient. So clinical presentation, patient will present with dyspnea, shortness of breath, temperature, increased exercise tolerance, because your cardiac output is not enough to sustain your metabolizing tissue. You have leg swelling because of sodium water retention. You have ascites. You have very high hypertension from back pressure to the lungs. You have hemoptysis from the urinary edema. You have things with hypertension and this cardiac output because the blood is not enough. Goes to the brain. You have sympathy and dizziness. You have systemic mobilization because the difference is dilated, and then you have hypertension. So this is the presentation of patient with heart failure, precipitating factors of ischemia, infection, drug compliance, arrhythmia, fluid assault restriction, anemia, aerobic depression. So when you see a patient with heart failure, think of the precipitating factor, because if you correct them, so clinical examination, patient will be drowsy, will have raised JBV, sinus tachycardia, dull rhythm, SCO, associated murmurs, you can hear crackles, you can see ascites, megaly, you investigate the patient, X-ray, renal function, because the patient is on ACE inhibitors and ARB. Check the electrolyte, especially potassium, look at the ECG, ischemia and arrhythmias, do the echo, with the diagnosis, assess the patient DNP, liver function test because of stasis, thyroid function test, liver profile, and thyroid study. So these are must investigation in every patient with heart failure. So the classification of heart failure, this is the hemodynamic classification. classification. I think the second slide is the first. So when you classify patients, you classify them into four stages: 1, 2, 3, or 4. So this stage is a patient whose cardiac output is more than 2.2. Cardiac rate is more than 2.2, which is really normal. He has heart failure, it's not valid. His lungs, the pressure inside the pulmonary pressure is normal. This patient does not have significant heart failure. Ejection fraction may be low, 40%, but is not clinically in heart failure. He has LV dysfunction. His lungs are clean. So this patient will be treated with what? Beta blocker, ACE inhibitor, spironolactone, but no diuretics, because his lungs are really clean. This patient has lower blood pressure. Ejection fraction is low, but he's currently the pressure inside his lungs are really high. When you examine this patient, you will feel happy. So this patient, in addition to the medication, has diuretics. This patient has low blood pressure, right? But lungs are clean. Pressure inside the lungs is normal. So his blood pressure is low, right? He's a beta blocker, ACE inhibitor, everything. So what would you do to increase this patient's blood pressure? No. Maybe he's dehydrated. Maybe he was in this stage. You are giving him too much diuretics. You push him to volume infusion. You give him some, increase the fluid amount. If you increase the fluids amount too much, what will happen? It will be hypotensive, pulmonary edema, cardiogenic shock. So this stage is really very critical. We have to be very careful when seeing those patients. So the typical scenario would be a patient comes with pulmonary edema, seen in the emergency department, too much lasix, goes into hypertension, too much fluids, goes into cardiogenic shock. Right. So when you see a patient coming to the emergency department with acute pulmonary edema, the first thing you would give this patient is diuretics. This is the dose, 0.5 milligram medication. Give morphine, because morphine dilates the vein inside the lung. Give oxygen. Give nitroglycerin if the blood pressure is low or high. Give dopamine if the blood pressure is low with lasix. Or give the vitamin. If the blood, then check the patient's blood pressure. If the blood pressure is above 100, then start ACE inhibitors, put them on the and look for other causes of the patient's deterioration. Now, if the patient's systolic pressure after you check it, it's really greater than 100, then the best medication would be nitrogen stream infusion with lasix. If the blood pressure is 70 to 100, there are no signs of shock, give vitamin. If the blood pressure is 70 to 100 with signs of shock, give dopamine. If the blood pressure is less than 70, we give epinephrine with a very strong positive pressure. What are the signs of shock?
Hypotension, tachycardia.
So measure the deliveries, sweating, nagging, physical consciousness, this unit out. So these are the signs together with hypotension. So now we've decided to admit this patient to the hospital. What would you do? So you really have to evaluate the patient's symptoms. Check the patient PNP, PNP. If the patient has ECG changes suggesting Purpura syndrome, send the patient to the cath lab or the RPS as much as possible. Look for other precipitating factors for the patient to go to heart failure, ischemia, severe hypertension, ventricular arrhythmias, infection, very embolism, renal failure, compliance, no medication, give the patient oxygen, assess the patient's shock status. Now, treatment for IV diuretics, always start giving very high doses of diuretics. Remember, when you have patients, you have to restrict his fluid intake to 1.5 liters a day, put a folic catheter, assess the patient response after 1 or 2 hours, see what's happening. Some patients, they go into acute renal failure, they don't open up the heart glass, the patients. monitor the fluid intake and input and output by polycatheter, measure the patient daily weight, because daily weight is the only way we can monitor patients. So we see usually the goal is to have 1 kilo loss in patient weight every day. Now, intensify the diuretic use. We give basics like we give 8 milligrams of start time basics infusion. You give spironolactone, you give calazone with basics to improve the diuresis. Now, try to really make the patient pressure as normal as possible with the medication, especially the antidote agents. Now, when the patient becomes better and improves, check the patient ejection fraction, start tasting inhibitors and ARB, and beta blocker only to be started when the patient lungs are clear. We don't hear any cracks. So if the patient is heart failure, we give beta blocker, we deteriorate the gene. Low salt intake is also very important. Right, so we always come and see that so the management is really ongoing management. We don't just start the medication and just medication. We have to see the patient every day and every 6 hours to see what is the results. Now, urgent catheterization is very needed in patients with acute myocardial infarction or unstable angina or stemming. Now, always restrict the patient fluids. Now, in basic hemodynamic monitoring is really class 2 indication, it's not really a strong indication. Now, if the patient is not really responding with the diuretics, you have to send them involve the nephrology team and ask them to ultrafiltrate or dialyze the patient, because this will improve his fluid status. Remember, this is, look at this is very simple, but I showed you in my hospital, one of the patients they are treated with heart failure. And the next day I found that he's taking very high salt diet, and then giving him 3 liters or 2 liters per day, and nobody checks his patient daily. So this is a very simple measure to improve the patient health. Medication, ACE inhibitors for life, beta blockers for life. If there's one medication for ACE inhibitors, we give ARBs. If there's one medication for ARBs, beta blocker give combination hydroxyl nitrate, diuretics, and injection in some patients. So this is the disease therapies, angiotensin, or the ACE inhibitors, beta blockers, or the epinephrine effect colony. So beta blockers are very strong agent, improve survival, reduces mortality by 34% with metoprolol XL. Cardiology reduces mortality by 65%. So this is the strongest medication for patients with heart failure. So when you use beta blockers, remember the contraindication, cardiogenic shock, systemic hyperperfusion, low blood pressure, overload, and bradycardia or heart disease. Now, should you stop a patient with beta blocker with heart failure? Let's say you have a patient with a beta blocker, come to the emergency department with urinary leak. What would you do to the patient with beta blockers? Nothing. Okay? Who says nothing? Who says I will cut it down by 50%? By 50%. Who says I will stop it because the patient will really his lungs are wet and beta blockers might lead to deterioration of the patient. Right. Okay, so this depends on the patient condition. If the patient is hypotensive, blood pressure is like 70, and there's signs of shock, this patient needs iron fortification to improve this patient's blood pressure. So those patients will stop beta blockers. Okay? If you have a patient with normal blood pressure, but very low, you give diuretics, we lower the beta blockers by 50%. Right? If the patient pressure is normal, mild practice, then the nurse patient will continue the medication, but I have to observe those patients before discharge. So when you start with the blocker, in the beginning, in the first 6 weeks, what happens to the patient? Beta blockers reduces the blood pressure, reduces the heart rate, reduces contractility in the beginning. So you expect in the first 2 to 3 weeks, up to 6 weeks, patient to deteriorate. You start the medication, and then the patient comes here, and you don't increase continue the same medication. We start with the blocker, we start with very small dose. And we double the dose every week, not every day, every week. After 6 weeks, look at the ejection fraction. So the ejection fraction, so it drops by 5%, but after 6 weeks, it starts to increase. So if the patient ejection fraction is 15%, and then after like 18 months and 2 years, the ejection fraction will improve by 15%. So the ejection fraction from 15% to 30%. And 40% almost normal. Beta blockers are very strong and very good medication for people. ACE inhibitors, they reduce mortality by 20%. It reduces hospitalization by 33%, reduces the MI by 21%. These are the studies. Consensus, Solvent, Safe, and CARE. So the treatment of patient heart failure. So if the patients treat the risk factors, if the ejection fraction is low, give ACE inhibitors plus or minus beta blockers. If the ejection fraction was at 40%, it means that this patient has vascular dysfunction, hypertension, or ischemia. Treat with ACE inhibitor, ARB, or beta blockers. If the ejection fraction is then 40%, combination ACE inhibitor and beta blockers. If intolerant to ACE inhibitors, give ARB. Titrate to the doses. So we start with a very small dose of ACE inhibitor, like 2.5 milligram of lisinopril. Beta blocker carbidopa, we start with 3.25 milligram. We double the dose every week. And then if the patient is tolerating dose medication, we increase the doses. If he's not tolerant to beta blocker, we give him cardiology. Patient is stable, continue the treatment. If ejection fraction is than 30%, we refer the patient to AICD, which is a defibrillation, because this is improved survival, prevents sudden cardiac death. Now, if the patient, despite all of these measures, continues to be in class 3 heart failure, we add rituximab on top of those medication, and we add something called resynchronization therapy, which is biventricular pacing. It remains after all of these measures, the patient is not really improving, we add spironolactone, and we consider the patient for transplantation. Now, these are the doses that patients with heart failure should be on. So we start carbidopa 6.25, the goal is 50 milligram. We start lisinopril 2.5, the goal is 20 milligram. Perindopril we start with 2.5 to 2 milligram, the goal is 8 milligram. Carbidopa we start with 3.25 milligram BID, and then the target is 25 milligram. Why 25 milligram? Because this is the dose that was studied in the clinical trial and showed the benefit. It's not the 3.25 milligram. This is the dose. That's it. Thank you very much. Any questions?